The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the BCIA Neurofeedback Mentoring Webinar, Treating Anxiety with Neurofeedback by Dr. Mark Jones. Mark S. Jones is a licensed counselor with a private practice specializing in the use of neurofeedback and other forms of biofeedback in the treatment of anxiety and other disorders. Additionally, he is the director of the Neurofeedback program in the counseling department of the University of Texas in San Antonio. During today's presentation, we will have a couple of breaks for questions and answers. You may send me the questions using the question function on the control panel of the GoToWebinar. Go ahead and find that now so you'll know how to do that. You can send your questions and we'll have breaks and he will attempt to answer anything that arises. Now, a little bit of housekeeping. Within a few days, you will receive an email with a link to a brief evaluation using SurveyMonkey. It won't take long to go through it, and we hope it will provide us with good information on how we suited your CE needs today or what we could do to improve going forward. After the evaluation, the next screen takes you to a little exam. Each exam item must be answered correctly for you to see the next question. The very last screen is your CE certificate, and the instructions indicate that you are to put your name in the box and print out that screen, Control P. So it's a pretty simple process. Some of you probably will forget to do that. That's okay. Call us back. We can get into the survey and find your completed survey, and we can send that to you. We're very happy to share this with you today, and I wanted to let you know we have attendees from 10 different countries outside the U.S., so I think that's kind of wonderful news. Thank you all so much for joining us today, and a great big welcome to Dr. Jones. You can start your presentation when you're ready. Thank you.
All right, this is Mark Jones. I do want to say that we were scrambling just a moment ago. The building I was in, the alarm went off, and so we had to vacate the building. So I grabbed my laptop and headed over to another building. So hopefully this will work. And I'm going to go ahead and get started here. So we're talking about treating anxiety with neurofeedback. This is from experience in my own practice as well as at the university here. We have done some research on the effectiveness of neurofeedback for treating anxiety symptoms. And so what I want to do first is first talk about anxiety and as it's classified into different diagnostic categories and the related symptoms. And I keep pushing the wrong button here. Here we go. Okay. Generally, anxiety is divided into 6 broad categories as far as diagnostic purposes. Generalized anxiety disorder, which is quite common compared to the others. Panic disorder, phobia-related disorders, social anxiety disorder, agoraphobia, and separation anxiety disorder. Taking generalized anxiety disorder first, the symptoms include kind of a general feeling of restlessness, feeling wound up or on edge. It also is accompanied by feeling fatigued, and there's some psychodynamic theories about how, you know, we tend to use up our psychic energy when we're anxious, and it could also be a carryover to the overlap of depression, and we'll talk about that later. Having difficulty concentrating, mind going blank. So you may have clients presenting with attention deficit issues, and an analysis and evaluation may conclude that they're actually having primary anxiety. Being irritable, muscle tension, so there are a number of physiological expressions of anxiety. Difficulty controlling feelings of worry, so there's a cognitive affective component as well. Sleep problems are quite common. difficulty falling asleep or staying asleep, or what we might call onset and maintenance insomnia, restlessness and unsatisfying sleep. I see clients every week who have anxiety disorders, and when we're doing EEG analysis, it's not uncommon for them to be drowsy during the recording, and that's due to the poor quality of sleep. Okay, taking the next category, panic disorder. During a panic attack, people report a pounding heartbeat or heart palpitations, or accelerated heart rate, sweating, trembling, shaking, shortness of breath, feeling like you're smothering or choking, can't catch your breath, feelings of impending doom, feelings of being out of control. One psychiatrist I heard said a panic disorder is when you know you're dying. And so for this reason, a lot of people show up at the emergency department with these symptoms and, thinking they're having a heart attack or they're dying. And usually the docs can fairly quickly sort that out with some tests and rule out heart problems. And then they're left with anxiety issues. All right, phobias. Phobias come in various forms, and we're all familiar with some of the classic terms, arachnophobia, this kind of thing. So there's an irrational or excessive worry about encountering something that is the phobic object, whether it's spiders or heights or it could actually take on just about anything. The person would actually try to avoid the object at any cost. And so there's the avoidance function. There's the experience of immediate intense anxiety upon encountering the feared object or situation. I don't know about you, but I don't like snakes. And I don't like spiders. So if I see a spider, I get the creeps, and I don't see snakes much, but if I'm out in the yard, I might see a little garter snake or something, but I get kind of spooked by it. I don't know that I necessarily would qualify as a phobia to the extent that I wouldn't go out and work in the yard because I might encounter a snake. There are some places here in Texas where you'd have to be careful of rattlesnakes if you live out in West Texas. So it's not an irrational fear, but we're talking about something that's really more of an irrational fear. So let's see, some of the examples would be flying, fear of getting on airplanes and flying, heights, different types of animals, injections, the sight of blood, excuse me. Let me get a drink of water here. Now on to social anxiety disorder, sometimes referred to as social phobia, has its own diagnostic criteria. There's general intense fear of or an anxiety about being in a social situation or a performance situation. These are folks that people are going to pick up on the fact that they're anxious. I don't want to go to the party. I don't want to go to the reception or to church or wherever it is because I'm anxious, and people will know that, and then I'm going to feel really embarrassed. So it's kind of a double layer there of having the primary anxiety of the social situation and then the fear of being anxious in the social situation. You find that with panic disorder as well, the fear of having a panic attack when you're out at the grocery store, this kind of thing. So as a result, folks with social anxiety tend to avoid social situations, and maybe they really like what the hobby or the club is doing, but they just really don't like going to the meetings because they're anxious about being around other folks. It can manifest and show up in a different range or a variety of situations. Can be prominent in the workplace or the school environment. I've treated children who would start getting nauseous and nervous and panicky on Sunday morning, just thinking about going to school the next morning. And so that's a particular manifestation of social anxiety disorder. Agoraphobia comes from the Greek for the agora, which is the meeting place, usually on an elevated level in the city. So the diagnostic criteria requires 2 of them or more of the following situations: using public transportation, getting on a bus or train, plane, being in open spaces or being in enclosed spaces, particularly if there's a crowd inside. Standing in line can be anxiety producing. Being outside of the home. I've had clients who would retreat to not just their home, but to a specific place in their home, maybe their bedroom or someplace, before they would actually feel comfortable or safe. All right, then we have separation anxiety disorder, fear of being apart from people to whom they're attached. It's not uncommon to see this with children. It's actually developmentally appropriate at some ages. But generally with adults, it can be an impairment to functioning, worrying that excessively about some harm or something happening to their loved one while they're apart. And sometimes you see this with parents who just seem to have an undue anxiety about children going out with their friends or this kind of thing. And the fear, it leads people to avoid being separated from their attachment figure and to avoid being alone. So if there's any way you can convince the person that you're attached to not leave you or take you with them or stay home or this kind of thing, you see those kinds of behaviors. It's not uncommon for people with separation anxiety to have nightmares about the separation, and even to the extent of having physical symptoms when separation occurs or anticipated. A lot of times this would be gastric discomfort, any number of nervous system manifestations of stress. So looking at the risk factors for anxiety and the developing of an anxiety disorder, it's been found that temperamental or personality traits of shyness or behavioral inhibition in childhood can be a predictor of the development of anxiety and anxiety disorders. The exposure to a stressful negative life event or environmental events in early childhood or adulthood is a risk factor. A history of anxiety or other mental illness in biological relatives, so there's a genetic connection. And some physical health conditions may precipitate anxiety or potentiate it. Thyroid or endocrine problems, heart arrhythmias. I happen to have been treated for heart arrhythmias, including surgery. And it was quite frightening when that first began. I can see why people might wind up in the emergency room if they're having PVCs or feels like their heart's skipping a beat or this kind of thing. I'm lucky I kind of just got used to it, but it can be very anxiety producing for some people. Caffeine is not your friend if you tend to be anxious. It's a cardiovascular stimulant. It's going to increase your heart rate, and other substances or medications can do this as well, and as a result produce or aggravate the anxiety symptoms. So there's such thing as the caffeine-induced panic disorder and this kind of thing. I don't know if it's just anecdotal, but there were reported increases in emergency department visits in proximity to university settings when energy drinks became popular, and it seemed that a lot of students would use these drinks to help stay awake and study into the night, and then they would wind up having panic attacks. So there's a substance that is contributing to that. So it's good to check in with clients, see when the last time they visited their physician, or to maybe recommend a physical checkup, and including endocrine metabolic issues and this kind of thing, because you want to rule out any kind of physiological issue. When I'm doing an EEG, I capture an electrocardiogram channel, and sometimes you can actually see arrhythmias in that channel. I'm not qualified to diagnose those, but PVCs will show up, or you can see a rapid heart rate or this kind of thing. And sometimes I recommend that folks check in with their docs about that. Okay. All right, let's look at some prevalence and severity statistics. And as you can see, I'm drawing heavily from the National Institutes of Health in this section. Prevalence of anxiety in adults, and I know we have attendees from various countries outside the U.S. I apologize for my statistics being limited to the United States. An estimated 19.1% of U.S. adults have had an anxiety disorder in the past year. So roughly 1 in 5 adults any given year have a diagnosable anxiety disorder. In the past year, prevalence of any anxiety disorder, including the 6 categories we just looked at, tends to be of higher incidence in females, 23.4%, than males, 14.3%. And you'll find a lot of these prevalence studies, there seems to be a disparity between the genders in these. I don't have the answer for that. An estimated 31.1% of U.S. adults experience any of the 6 anxiety disorders at some times in their lives. So roughly 1/3 of individuals in this country have anxiety enough to interfere with their functioning. And even though this is a 2017 report, the data is based on some years ago, 2001 to 2003. Looking at it in the bar graph form, we see the 19.1% overall prevalence of anxiety, higher in females than males. And then to break it down into various categories of age, 18 to 29, 23.3%, similar prevalence in the 30 to 44% range, or age range. Drops off a little in the 45 to 59, and I guess there is something to look forward to in old age, and that is we don't tend to be as anxious. I'm in that group, by the way. I do okay until the fire alarm goes off. Okay, so here's a pie chart talking about severity. Most of the cases would be in the mild category, 43.5. Moderate, a good third, and a little bit less than fourth of the cases would fall into the serious category of symptoms. Looking at similar prevalence rates among adolescents ages 13 to 18, estimated 31.9% of adolescents had an anxiety disorder in any given year. 8.3% of those have severe impairment. I believe that may be 8.3% of adolescents have a severe impairment due to anxiety. Prevalence of any anxiety disorder among adolescents was higher for females than males in the adolescent population as well. And tends to be similar across age groups, as we can see here, 13 to 14, 15 to 16, 17 to 18 years, pretty similar rates of prevalence across the board. So I think it's safe to say teenagers in the United States tend to be pretty anxious across the board. Okay. All right, this would be a good place to stop. If there are any questions regarding the statistical analysis and diagnostic criteria for anxiety disorders.
We do not have any questions at this time. Remember, folks, if you have a question, please enter it in the question box on your control panel, and we'll have more breaks like this where Dr. Jones can take your questions. Thank you so much.
Okay, all minds are clear. Talking about anxiety in the brain. This is a 10-10 electrode diagram taken from the Thompson's book, the Neurofeedback book. The 10-20 sites are colored in light green, and then the red circles are around the sites that would correspond with the affective network. So we see the frontal to central midline. We see the temporal to posterior temporal regions, as well as the frontal temporal regions. And this is a little bit further outside what we would normally place as F7. So we're really getting around to the side of the frontal cortex here much more. Okay. Yeah, excuse me. This next slide is from Catani and Company, showing the various connection fasciculi. We're talking largely about the limbic system, and I think this is of particular importance that we see these diagrams of connective tissues, okay? And so we see the cingulum, which corresponds with the cingulate gyrus from the anterior around to the posterior cingulate, and heavy associations all along this area. So this is going to associate with that frontal to central midline area that the Thompsons were identifying as part of the affective network. We see some other key connection paths, but to point out that we see connections here into the prefrontal cortex, as with the uncinate gyrus, which is connecting from the limbic system into the medial prefrontal cortex to a large extent. Oh, I'm looking at the wrong one. This is the light blue. And then the inferior frontal occipital fasciculus which is hidden from view, but this is more or less into the anterior cingulate medial prefrontal cortex, traveling all the way back to the occipital areas. The fornix, which we have pathways somewhat hidden by the cingulate fasciculus, the mammillothalamic tract from the mammillary bodies, and then this long tract of fibers, the inferior longitudinal fasciculus, and this is along with some of these other connective areas tying into the temporal lobes back into the posterior areas. So these are many of the pathways that are going to be involved in the affective, and we'll see later into the fear network, at which point I'm going to look at some diagrams by Kahn and associates, looking at pathways that are involved in cognitive emotion regulation. I'm going to break this down a little bit. So let's imagine you're walking in your yard or park and you see some long green tubular object. I don't know about you, but I think instinctively I would say, oh gosh, there's a snake in the grass. And we can see in the diagram which areas become activated at that point. We see that the ventrolateral prefrontal cortex and the insular cortexes are involved heavily. We get associations from the amygdala and basal ganglia coming into these areas, as well as the anterior medial cortex. And we're into the anterior cingulate as well, sensory motor association area, and the indirectly with the superior temporal gyrus. So here we see the temporal lobe. This is the brain kicking into gear to deal with the belief that there's a snake in the grass. It's a hose. So this is the ramping down of the system and the areas that are involved with that. We see at this point the dorsolateral prefrontal cortex is pretty key, as it takes associations from other frontal areas, including the insula. And we're chilled out now. We're not worried about the snake, probably not the hose either. So we see that the regulation is basically being restored with these pathways, which are highly impacting upon the amygdala and basal ganglia here. So there is a period of returning more or less to baseline. I would point out that with folks with PTSD types of issues, there might not be the return of regulation quite so quickly, if at all, because these circuits tend to be over-aroused and stuck in an over-aroused state. Here's another way of looking at these same areas. We have the anterior cingulate involved, amygdala, and we can also see the insular cortexes involved bilaterally in the, and these are the brains of folks associated with an agoraphobic cognition. Yet another way of looking at some of these connections, the ventromedial prefrontal cortex. So what we have here is areas that help to regulate and modulate limbic arousal. And so, for example, if this area is underactivated, which you find with some anxiety disorders and PTSD, then it's not having as active a role in modulating limbic arousal, and also the function of the dorsal anterior cingulate cortex I don't know if you can see, this is like a quarter section taken out of the brain, the left frontal lobes. The insular cortexes are highly involved. These areas, one of their functions is monitoring the physiological state of the body. And for example, when there is heart-related anomalies such as rapid heartbeat or arrhythmias, that would catch the attention of the left insular cortex, as it tends to monitor the right side of the body, and the heart is, I'm sorry, I've got the other way around. The right insular cortex monitoring the left side of the body, and the heart is primarily in that hemisphere. Amygdala, hippocampal areas. And just for reference, the amygdala is, as some would call it, the fight-flight center. Gives emotional tone to our experience, highly associated with the hippocampus and memory. Certainly with PTSD, these amygdala area, the area and surrounding associations are over-aroused while the hippocampus would be under-aroused. And in fact, with chronic PTSD, might even have a lower than normal mass or volume. And we would also see the prefrontal cortex, medial prefrontal cortex, under-aroused and not able to modulate the limbic amygdala area. And a few other markers here. This is the rostral anterior cingulate, sometimes referred to as the genule because of the genu of the corpus callosum, dorsal anterior cingulate, which is above it, still in the anterior area, highly involved in the regulation of emotion in the fear network. And another look at the insular cortex, which is kind of hidden behind the temporal lobe. You might see pictures of physiologists pulling away the temporal lobe to reveal the insular cortex. All right, an interesting diagram. This actually came from a neurobiology study of postpartum anxiety and depression. I think it does a wonderful job of demonstrating the overlap in brain areas of anxiety and depressive processes. So areas in the green related to depressive disorder, areas in the yellow, general anxiety, and we see that some are involved in both. Here is the insular cortex, and if the color is a darker green, that means increased activation. If it's a darker yellow, increased activation, but relating to anxiety and depression. And we see a similar overlap in the amygdala. In both cases, both these areas are over-aroused. And then we see some under-arousal, as I was indicating earlier, anterior cingulate, prefrontal cortex. This is the orbital frontal cortex. This is not labeled, but we can see that this is up in the dorsal area of the frontal lobes. And then the hippocampus and the striatum, nucleus accumbens, tend to be over-aroused in this case. So it's a neat diagram for looking at the overlap. There is a large overlap between anxiety and depression, which accounts for one of the reasons antidepressants are sometimes used to treat anxiety. This is another diagram showing the insulinate fasciculus with its connections to the prefrontal cortex. And what you can't see here is it's coming around to the temporal lobe as well. The study is showing reduced connectivity in this area involving the medial prefrontal cortex and the limbic area and the amygdala. including the anterior cingulate. So this is what I refer to as the brakes of the brain and the inhibitory function that's involved here. And so there is often areas of over-arousal, but then areas of under-arousal and areas with functions of inhibiting the limbic area and this kind of thing. Okay, that was anxiety in the brain. That was a pretty fast overview, but this is a good time for questions.
Okay, let's see if we have questions in this section. Oh, and I think we do. This is a logistical question. Denise had sent the handouts earlier this week, but it's on black and white. Is there a way to get the color slides?
Yeah, those were, I guess, for some purpose were requested in black and white. I do have it available in color.
Here's what we can do. We can make them available in color, and we'll post them on the web page that hosts where this recording is going to live, where the handouts will live, where the exam will live. And so then anyone who wants it could go on, get the colored slides and from the handouts and print maybe just what they want. People complain when we send colored handouts because it says it uses up all their colored ink and their company doesn't allow or whatever. So that's our policy, to only do it in black and white. But I can certainly understand why some of these slides would be lovely to have color. So if that's okay with you, Dr. Jones, that's exactly how we can handle this.
Okay, works good for me. And I've actually made a few changes to the PowerPoint, so it'll be a little more updated.
Perfect.
Okay, so looking at, were there any other questions?
Let me see here. It does not look like it. It looks like that's what we had. That's all we had.
Okay, great.
Thank you.
Okay. Common treatments for anxiety. These are typically standard of practice treatments. Cognitive behavioral therapy would certainly be at top of the list. I know there's all kinds of ways of doing neurofeedback. In my private practice, I integrate cognitive behavioral therapy and other forms of therapy with the neurofeedback process, particularly with anxiety, maybe doing a form of desensitization therapy or other forms of cognitive behavioral strategies. Medication is often prescribed, anxiolytic or anti-anxiety medications. One of the chief classes of drugs are benzodiazepines. I think I have a list here: alprazolam or Xanax, clonazepam, Klonopin, lorazepam, Ativan, are the typical ones. This Versed is benzodiazepine, but it's used mostly for, as far as I know, for medical procedures. And what you get with these benzodiazepines is a marked increase in beta activity in the EEG, and it just co-opts the EEG. If you've taken a Xanax or one of these drugs prior to the EEG recording, sometimes that's about all you can see. And for chronic users of these drugs, they can continue for weeks, maybe even up to a month, the effect that it may be having. My belief is, I don't know how well founded, come to think of it, but that what we're seeing is the activity of the GABAergic pathways and the inhibitory pathways in the brain. It's sometimes referred to as a benzo buzz or a beta buzz. In fact, I don't know if I have a slide for that or not. But, also, some decrease in alpha and overall voltage of the EEG is an effect of these drugs, as well as a slight increase in theta and a lessening of paroxysmal activity due to the anticonvulsant nature of benzodiazepines. Sometimes used as anticonvulsants, at least historically. Buspirone is another drug commonly used. Antidepressants, commonly used. SSRIs, not uncommon to have clients who are on Zoloft or some form of SSRI, which can have positive effects on anxiety. Tricyclics, MAOIs. Generally, these drugs come with a black box warning because they can, on rare occasions, actually increase suicidal thinking. Beta blockers are used, and generally for the purpose of managing heart rate, which is a cue to the brain that often results in anxiety. Support groups, stress management techniques are also listed. Of course, our interest here is neurofeedback, and I am particularly interested in QEEG markers for anxiety, which gives us a target for training. I'm going to try to plug in my mouse here. Let's see, here we go. All right, so some of the markers that have been identified in the literature and are the basis of my treatment in general, excess beta or high beta, and as Johnson Walker in Dallas says, you just train it down no matter where it is. And we don't generally need high beta frequencies in the brain. Excess midline beta or high beta, which would be associated with the cingulate issues, sometimes referred to as a hot cingulate gyrus. Frontal hypocoherent alpha is also can be a marker for anxiety, and we'll look at some examples of that. Frontal presence of alpha, and let's see, attenuated posterior alpha. Attenuated alpha can be a marker of anxiety. I also see it a lot with PTSD. And then a low amplitude fast in the phenotype, where you see an overall low voltage of the EEG, but it's usually called fast in distinction to a low voltage slow, which would be possibly a marker of pathology in the cortex. Looking at the brain with a Loretta low resolution, you might see under or over arousal in the medial prefrontal cortex and the anterior cingulate. And with the Loretta, sometimes you can see that part of the anterior cingulate that is more ventral, which is hard to read from the surface. Looking at the EEG itself visually, you can see at times beta or high beta spindles, and I'll give you some examples of those. But just some diagrams here of brain maps. This would be the low amplitude or the low voltage fast, and it looks like all of the bins are below average or generally so, and in the NeuroGuide scheme that would be kind of in the blue or bluish green area, and that's an indicator of low values in the power range. The frontal hypocoherent alpha, you may see elevated alpha excess Z-scores in the front of the brain. Low alpha, you may see decreased Z-scores posteriorly, and that's of particular interest in the eyes closed condition when you would expect to see a continuous sinusoidal alpha rhythm. And then there are high beta subtypes or beta subtypes that you might see centrally or along the midline. Here's an example of a low amplitude fast. I'm going to show you some comparisons in a moment, but here are the occipital leads in the middle. The alpha is somewhat attenuated. There's kind of a flatness to the EEG. I normally view EEGs at 100 microvolts. If you're finding that you have to lower the scaling to enhance the morphology, then you might want to look more globally, see if you don't have a low amplitude or low voltage of fast EEG. Looking at these from Power Spectra, some examples here. These are Z-scores, okay, and this is actually a client with a fast alpha peak frequency, which is often associated with central nervous system, just general central nervous system over arousal. And so the training was at PZ, eyes closed, and we were trying to train up the slower edge of alpha. I don't know how successful we were with that, but we did actually, in the training, the alpha Z-scores increase, but they remain quite fast, actually 12.5 to 13 hertz. Here we see, this is the Z-score, 13 hertz. On the absolute power, we see that the speed of the alpha tuning is more around 11 to 12. Now, why would we see it at a different frequency with the Z-scores? Well, we're looking at two different things. This is the absolute power. This is what is we're measuring at the scalp. And the Z-scores are comparing to a normal, and most people don't have 13 hertz alpha peak frequencies. So if it's present at all, it would usually show an elevation in the Z-score. So the Z-scores aren't necessarily helpful in identifying power increases. In this case, it's a frequency increase. Here are some other spectra of low amplitude fast. Here's one with a midline high beta. And so you can see in general, the voltages are low. Now, we might say this is not statistically, it's not below 2 Z-scores or standard deviations, but it has a low appearance, and you'll see some blue heads on the topographical maps. This does increase as the frequencies increase, and we'll see on the maps where that was localized. Now, in the absolute power, you just see kind of a 1 over F curve to an extreme where things just seem to flatten out. Here's the topographical maps, and this is what I mean by just the overall low amplitude, but toward the faster frequencies, it does become localized in the frontal midline. This is relative power. You certainly want to look at the absolute power before you look at the relative, or you don't know what you're looking at. So this is accentuating this high beta activity in the central regions of the brain. Okay. This excess 1 hertz is typically an anomaly from the amplifier being more sensitive toward the DC range than the database is. Okay, now this is what I mean by looking at the raw EEG. This is a low amplitude fast, but it has a particular characteristic here. And these are, some might argue with me, but these are beta spindles. They're not the highest amplitude you might see, but there is a spindling beta, and it's not just a one-time occurrence. You would see it repeatedly throughout the EEG, and just kind of magnifying that, you can see that there's a definite increase in this beta activity. And if we look at it on the spectra, who's to know where it's coming from? It just looks like a high beta elevation. The maps help us localize it, but these do not help us understand the significance of the waveform. This is starting to manifest a easily kindled cortex Okay, so it's a particular vulnerability to symptoms such as anxiety. Okay, here is the relative power emphasizing the parietal source of those beta spindles or localization. I want to talk about the fast alpha variant. This is a 12 hertz alpha, and you can count the alpha waves in 1 second increments. 12 is generally kind of fast. We normally think of alpha as 8 to 12 hertz. In this case, the whole band is shifted up a couple of hertz. The band is 10 to 14, and the peak is at 12. And we can see that looking at the spectra here we have. It's actually quite a nice peak. It's very consistent in various channels. It's right at 12 hertz. And on the z-scores, we see another phenomenon. We have the 12 hertz alpha, but then we see a secondary peak. Now, you would want to look at this. This looks like elevated beta and high beta, and there possibly is some of that manifested here. What you might not have paid much attention to is just the ever so slight elevation here in the raw scores. Doesn't look too significant, but there's something that's going on. And actually what's happening, particularly with a pretty good voltage to the alpha, it is, there's an anomaly with the Fourier calculations. The Fourier is seeing a secondary frequency. Some of that's due to an alpha having a bit of a sharp morphology. So this second peak is actually a harmonic. It's not necessarily produced by the brain. And so someone might see this peak and go, oh my God, look at all this beta, let's train that down. Well, and to the extent that you're training down the harmonic, you may also be training down the origin of it, which would be the alpha activity. And you may not want to reduce the alpha power. It is quite fast, however. Here it is on the topographical maps, and you see what I mean by the whole band is shifted up, so it's exceeding the z-score thresholds in a wide variety, even though the peak here is at 12. So you see it having a band effect. Any questions so far?
Okay, let's see. Oh, we have a lot of questions. I've got to get to the top of the list here. Can you say more about it says something like breaks of the brain. Does that make sense? B-R-A-I-K-E-S?
Yeah, I was looking at the, let me see if I can go back to that slide. Sometimes I tell clients if the brain were an engine or a car, this would be the brake pedal. And because of its inhibitory function, and it functions to regulate the over-arousal or the arousal level of the limbic system, among other things. And so sometimes people will have an over-arousal signature, but then you'll also see an under-arousal in an area that is there because the over-arousal is not being mediated. And so I would say, well, this is like the brakes. This is like the brake pedal of the brain. You get your foot all the way on the gas, but the brakes aren't working so well. So that would be the analogy.
Great, thank you. Will we be able to access this recording at a later date? How long will it be available? Yes, of course you can have a copy of the recording, and once you have a copy of that, you can play it as many times as you want to, you know, and sometimes a lot of people want to play it in pieces because it is a lot to digest. So make sure that you get a hold of Denise at info@bcia.org. Let her know that you'd like a copy of the recording. All right, how do you explain the increase in beta, which we associate with greater contact and cognition, or even anxiety itself? Does GABA release increase beta rhythms?
Yeah, let me answer that this way. Various neurotransmitter pathways, such as the GABAergic, may be firing along in a beta rhythm, but their function is inhibitory. Whereas you might be looking at a serotonergic pathway, which is firing in the beta range, and that is an excitatory pathway. So it could be that these GABAergic medications are boosting GABA levels, which the brain uses as an inhibitory function for overarousal. And so you may be seeing increased beta, but it's of an inhibitory type. So unfortunately, it's, as far as I know, impossible to tell the difference in an EEG, if what the source of the beta is.
Are we ready for the next question? Dr. Jones?
Yes.
Are we ready for the next question? Your voice cut off, and I'm not sure whether it was just a hiccup in the IT or...
That's because I quit talking.
Okay, perfect. So are you ready for the next question?
I hope I answered it adequately.
Good. All right. What about biofeedback with focus on diaphragmatic breathing as treating anxiety symptoms and promoting self-regulation?
Sure. Yeah. Now, we're talking about neurofeedback, which some would say is a top-down approach to the central nervous system. But peripheral biofeedback is very complementary. And in fact, I've had good success treating anxiety and panic with peripheral biofeedback. In one case, skin conductance. Breathing is a key respiration-based biofeedback, skin temperature, heart rate variability. There's a number of biofeedback mechanisms that are helpful with anxiety because it's helping a person regulate sympathetic nervous system arousal. And so you're affecting the brain function by affecting the body stress response, whereas neurofeedback tends to work the other way around.
Okay. Next question. What is meant by the attenuated alpha? How is that attenuation recognized in the QEEG?
Yeah, basically attenuated means it's low. It's low in power. There's not as much of it as you would expect. And I've got some slides coming up that I'll show you the difference between what might be a normal level of alpha and an attenuated alpha.
Great, thank you. Do you see these Q marker subtypes in combination?
Yeah, sometimes you'll find complex cases. I actually treat, more so in my practice, a number of clients with anxiety who also have ADHD. And anxiety can mimic ADHD, but with these clients, you're also seeing the classic frontal slowing that you would expect with ADHD, but then there might be some overarousal. In some of these cases, stimulant medications are a disaster because they are exacerbating the anxiety symptoms. So neurofeedback may be of particular benefit in those cases because of our ability to target location and frequency.
thank you. Next question. Please explain further the low amplitude fast wave morphology, especially the fast descriptor.
Yeah, I wish I had a low voltage slow EEG. Low voltage slow EEGs are often seen with encephalopathy conditions, metabolic liver failure, this kind of thing. These are very, very sick individuals, and brain function is slowed dramatically to a pathological level. So the term low amplitude fast is really to make a distinction. This is not a low amplitude slow. There is a comparable amount of beta or faster activity in the EEG. It's just that the EEG itself is low amplitude or low power. It seems like there might have been another aspect of that question, but I can't remember.
Want me to repeat the question?
Sure.
Let me pop up one. Please explain further the low amplitude fast wave morphology, especially the fast descriptor.
Yeah, I think that's what I was trying to accentuate. And sometimes you actually do see the faster frequencies come up in power compared to the EEG as a whole. And sometimes it is a low voltage or low amplitude EEG with a little more high beta than you might expect.
Great, thank you. Next question. Please describe the simplest neurofeedback protocol that can effectively treat anxiety.
Yeah, I know there's a tendency to want to do symptom-based training. I think it's very helpful to know and be able to make some distinction between some basic types. And we're going to talk about various ways I approach this. For example, with low amplitude fast EEGs, I tend to want to train alpha in the back of the head, such as PZ, and we'll see can have a positive effect. If there's not attenuated alpha, then based on some other markers, I'm train something else.
Okay, thank you. Next question. Would you ever not train down a harmonic?
I basically never train a harmonic. I train what is actually a brain frequency, a brain signal. A harmonic is like a mathematical anomaly in the computation of the frequency and power measures of the spectra. So I think it's very important that you identify the harmonic. I'm going to go back here. The giveaway here is that we have a 12 hertz alpha. And a harmonic is exactly twice that. So if you look over here at 24 hertz, bingo, right? So this is harmonic, and it's very high in Z-score, and you'll see them show up in the Z-scores. Sometimes you can actually see the harmonic show up on the absolute power, but that's still the Fourier is seeing the waveform and is mistakenly seeing a second wave at twice the frequency. And so I personally see no reason to train down a harmonic. If you're training this down, then you're basically training down this alpha, which is producing it. So in this case, I don't know that I would want to lower the alpha power, so I wouldn't want to touch this harmonic.
Okay, great. The next one was more of a housekeeping question. It says, can I repeat the email address for Denise to send the to send the recording? what I'll do is we'll just send a copy of the recording to everybody. What we do is we send a web link, and it'll have a copy of the recording. It'll have the handouts. And then when we have time to get the colored handouts from Dr. Jones, so you could pick some of those slides that really do better in color, we'll send all of that to you once we get it, okay? All right, next question. What about CES, cranial electrostimulation for anxiety?
Somebody had to ask. I can't really speak. I know that sometimes like these devices can be helpful for some people and may not so much for others. Within the scope of my license in the state of Texas, I am not willing to put electricity through my clients' heads. I think I would leave that up to those who've been to medical school. So I do not use any electrical stimulation techniques at all.
Thank you. That was a great question, and I think a really good answer. I think people need to think very, very carefully what that could look like to a licensing board. All right, next question. Do you make sure your patients are off of meds when you do the QEEG?
It is nice. Now you have to understand if a person's been on a benzo for some time, laying off of it for a few days could actually elicit some withdrawal symptoms, and it's probably not going to diminish the effect of the medication much. If a person, for example, takes a Xanax, PRN, maybe they take one to help them go to sleep one night a week or something. I ask them, and I always preface these discussions with, you know, this is between you and the prescribing physician, and that it is helpful if you can have folks off the medication long enough to achieve a significant washout. Stimulants, for example, will increase high beta and reduce low frequency activity. And, you know, it's not difficult many times for parents or clients to come in on a Monday morning early, first thing, for a QEG and have laid off the Ritalin over the weekend. And they can take their dose right after the recording and then go to school or work. It really is a dialogue to have with the client and the prescribing physicians, particularly folks who are somewhat fragile psychiatrically. They're on some very powerful drugs. I don't even sometimes bring the issue up. But the point is that medications can so pollute the EEG that quantitative analysis is useless. At that point, I fall back on just symptom-based kind of protocols.
Okay, thank you. What is your recommendation for treating someone with an overall low alpha presentation?
Low amplitude or low frequency. Low amplitude, I would try to train up alpha, eyes closed. I usually put the lead at PZ. That also is getting at the default mode network. But if they have a fast alpha, I'll try to train the slower side of alpha to help them gain a little more flexibility when their brains idle down, so to speak. But generally is training up alpha in the posterior area.
Okay, next question. How do you treat beta spindles?
Yeah, you identify the frequency and the location, and I basically inhibit that frequency. And these are often localized in the frontal area. So I would likely also reward low beta, 12, 15, something like that, which is a little more of a regulating rhythm. And So basically just down training the frequency of the spindles.
Okay, next. Can you effectively train to reduce anxiety if client is taking an SSRI?
Yes, there's a difference between trying to do a QEEG on somebody on meds and doing neurofeedback to somebody on medications. I found that you can still have a positive effect with medications on board. However, I will bring up the benzodiazepine issue again. That really blocks the process in my mind. And so sometimes neurofeedback is contraindicated because of the medication effects. But SSRIs will increase beta. But if, for example, in cases of attenuated alpha, you still got a marker there you can train.
That looks like it's all of our questions for this. That was a long question section. You did great. Everybody, thank you for sending things in. And so I think, Dr. Jones, if you're ready to go on to your next section, I think we're ready to hear.
Okay, Judy, I see we got about, 15 minutes?
Yes.
Okay, so I'm going to kick in high gear here. Okay, the study we have published from the program here at UTSA was retrospective. In other words, the treatment was provided, the data was cleaned of any identifying information or de-identified, and we did not have control groups. We did look at all 40 subjects that came through for treatment that were willing to complete pre and post assessments, which included QEGs, completing the Zung anxiety scale, and the ASEBA, or the Achenbach measures for their age group. And bear in mind, the context was in our training program, so the feedback was provided by master's and doctoral level counseling students. So the idea was to see if we could provide symptom improvement with QEEG guided one-channel neurofeedback, and that was our goal, and that is partially because most neurofeedback practitioners can do 1 to 2 channel neurofeedback without much special equipment, and so let's see if we could have an effect with a very basic form of neurofeedback. What we had overall was a decrease in Zung anxiety scale reports, a decrease in the Achenbach anxious depression scale. There's a number of scales in that report. Also a decrease in the Achenbach anxiety problem scale, as well as the total problem scale, which is a scale that samples various scales, and so in a way is an overall reflection of emotional well-being. All scales were brought down to a normal range of functioning, and the average number of sessions was 12. Why so few? Because we concluded the treatment at the end of each semester. So another reason for that is I wanted students to be able to see the effect of neurofeedback during a 1 semester period, and anxiety does tend to respond fairly quickly. Here are the statistical results of the test, and so we had good significance and good effect sizes on the scales. I wanted to look at a couple of the clients that went through the program. And this is attenuated alpha cases, so hopefully this will answer some questions. I want you to just train your eye on this EEG. Now these 2 channels right across the middle. This is 01, 02, so this is the occipital channels. And it's kind of hard to see PZ, but it's down at the bottom. But we're basically looking at these occipital alpha. This is eyes closed. And it's not the prettiest alpha I've ever seen, but I was looking for something that was of normal amplitude, and this is about that. So just kind of train your eye on looking at this normal level of alpha. Now, this is one of our cases. Do you see the difference? Okay. Alpha that's visible, alpha that's really not visible, and we see a little bit of alpha. Definitely would call this slightly attenuated. It's very attenuated with case 1. Case 2, we do see some alpha, but it's below what you would normally expect. Okay, so hopefully that'll give you a feel for what we're talking about with attenuated alpha. First client we're going to look at is a 47-year-old Hispanic woman. She had anxiety, depression, had been diagnosed with bipolar disorder. So this is not as clear a picture as we would normally like. She had a motor vehicle accident in her 20s, so that would have been some 20 years prior, with a blow to the right posterior area of the head, loss of consciousness, and a concussion. Personally, I didn't see anything in the EEG that reflected that. Her QEEG type was a low amplitude fast with attenuated alpha, and her alpha was measurable at 10 hertz, so that's pretty normal frequency. The protocol was eyes closed, PZ, and we decreased 4 to 7 hertz and 25 to 30 hertz. And one of the reasons people use that high beta inhibit is not that there's high beta there, but to discourage muscle tension. And we were increasing the full alpha band of 8 to 12. So in the learning curve where we tracked her 11 sessions, we see that at least for the first 6 or 7 sessions, there was a nice increase, at least in the trend line here. It kind of tapered off, but she was able to increase alpha rhythm. The inhibit bands stayed fairly low. This is a pre and post QEZ section of the major bands, attenuated or low amplitude EEG. And we could see that the alpha actually normalized a bit compared to the other bands. And she had a 14-point reduction in the average of the 3 Achenbach scales that we looked at. The anxious depressed scale, she actually reduced her score from a clinical significance to borderline. Anxiety disorder from clinically significant to normal, and total problems from just a borderline elevation to clinical. So in her symptom analysis or feedback, she reported some decent improvement. She had a 13-point reduction on her Zung anxiety scale, and which brought her down from the moderate to mild to moderate range into the normal range. Case 2 is a 44-year-old Hispanic female, and she had a long history of general anxiety with insomnia. And I noted that when I looked in the records, there was a comment that she was taking her citizenship test and then that she had passed it. So I'm wondering if some of her initial anxiety presentation she was worried about this test. I think it's important to keep up with events like that with clients. She did have a low amplitude fast with attenuated alpha, also at 10 hertz in her EEG. And a very similar protocol, eyes closed PZ. In this case, we inhibited 3 to 6 due to her EEG, QEG results. And we were also reducing elevated beta in her case, 15 to 20, and increasing the full alpha band. This is the kind of learning curve you like to see. You see this nice increase in the alpha frequency from session to session, and here was a 12 session round, and the inhibited bands pretty much stayed flat there. Her QEEG again showed a slight normalization of the alpha band, possibly as a result of the training, maybe because she felt so good about passing her citizenship test. It's up for debate. The Achenbach had a 19-point reduction overall, clinical to normal on the anxious depressed, clinical to normal on the anxiety disorder scale, borderline elevated to normal on the total problem scale. And on the Zung anxiety scale, 20-point reduction, which took her from the mild to moderate clinical scale to the normal range. So there's a couple of clients that claimed and demonstrated symptom improvement. And that is the end of my slideshow. Any questions?
Let's see what we have here. I have to go back and catch up to where we left off. Here we are. Please repeat CE instructions.
Can you repeat that?
Yep. Can you please repeat CE instructions? I wonder if that's continuing education. If that's me, or did you talk about CE?
I didn't talk about CE.
Okay, CE. We'll send an email out to everybody with everything you need to know about the CE. You probably will get your email from us on Monday or Tuesday. Here's a question for you, though. Did the use of only one channel become a constraint in addressing anxiety? I ask because I think in terms of networks and wonder if there are more important areas of certain networks, for example, default mode network.
Oh, yeah, for sure. We were limiting our approach, but also demonstrating you can have an effect with that. Now, the data is simply not there to show the superiority of Z-score or other forms of multi-channel training. Even though the data is not there, I would agree with a lot of folks that these modalities can be more effective. And if you have that capability, that's something to consider. But that was not the scope of the study. In my practice, we use a variety of approaches, including one channel. And for complex cases, we may go to 19-channel or 4-channel. Might go to 19-channel Z-score or 4-channel multivariate coherence training.
Okay, next question. Would you use ISF or ILF, low frequency, for anxiety or stay with amplitude?
I have no experience at all with those slow cortical potential, low frequency types of training. So I really can't speak to that.
Okay. Maybe we can have a low frequency presentation and they can address it.
There you go.
Yep. Any cases with high beta?
Yeah, I was wondering, I was trying to find some representative examples. It seemed, and of course I was looking for those who seemed to have the most potent effect, and it seemed to be among those who got the alpha training. And that was also a predominant presentation among the 40 clients. And so that would have been nice if I'd had a beta spindle example or a high beta example, but sorry about that.
That's okay. We might just have to have you back.
Oh, no.
Oh, great. How often?
Okay.
Okay, everybody, you have a lot of witnesses now. How often were the neurofeedback sessions?
We trained twice a week, Mondays and Fridays, and the neurofeedback Training itself was 30 minutes each time.
Okay, thank you. Do you have patients practice gratefulness or connection to loved ones while training up alpha?
That's a great question. For the sake of trying to keep the approach as uniform as possible, we tried to limit some of the other types of therapeutic interventions. We used sound and encouraged slow breathing for the alpha. In my practice, we may use a number of techniques, meditative practices, focusing on a safe place, this kind of thing to enhance the alpha production.
Great, thank you. Next question. Have you incorporated Z-score training for anxiety disorders, i.e. rewarding decrease in high Z-scores and strengthening low scores?
Yes, in my private practice, we do, and particularly if the symptom presentation warrants it.
Okay, great. Next question. How about treatment for high beta?
Well, basically, you're going to see the frequency range for the beta in the QEEG, so you would want to, and where it is maximal on the scalp, and basically it's a matter of inhibiting that with the EEG. I think I mentioned earlier, I do like to train up a lower beta if the QEG warrants that. I feel like I'm giving the brain something more normalizing and regulating in exchange for reducing something that's dysregulated. So that's kind of my approach.
Okay, great. Thank you. This is incredible timing. I think we just finished the last question, and look at our time.
Yeah, fire alarm to boot.
How about that? Yeah, I thought we were a very brave group. Well, you braver than anybody because you're the one with the fire alarm and the police helicopter circling overhead. We're glad you're safe, and we hope that we won't hear anything different after we leave. If anybody thinks of anything the way I would hang up the phone and go, oh, I should have asked that. Don't be afraid to email me. And what we can do is collect some of these questions. I'd rather you email me at BCIA, and then I can send a group of these questions to Dr. Jones, and he can send answers, and then we'll send them out to everybody, or we can post them on our website when we get that link. I have the page built, and I have everything I need except the recording, and I have to reformat the recording and do all kind of IT monkey shines to get it so it's available for you. And like I said, we will have that available for you Monday or Tuesday. So anyway, I think that concludes our presentation today. Dr. Jones, thank you so much. It was a great experience. I know everybody learned a lot, and I know people were very attentive. I've never had this many questions, and that's a good thing.
Hope it was helpful.
Good thing. I'm sure that it was. Oh, I just got another chat or another question. And it's not a question, it's a comment. It says, thank you, with about 14 exclamation points. So thank you so much. I enjoyed it. I know everyone else did. I hope you'll go back to your building and everything is safe now.
Thank you.
This concludes our presentation, and I think we're going to have to make you come back. So be thinking about all the things we'd like him to teach us the next time, and you can send me an email on that too. Thanks, everybody. Have a wonderful weekend. Take care.
Bye-bye.
Bye-bye.